Hello, and welcome back to Wellness Wednesday, where we share practical wellness tools and techniques from experts on topics that are important to patients, survivors, and caretakers alike. I'm Erin Kuhn-Krieger, and I'm so thrilled to be back for this session where I'll be co-moderating with our partners over at Cancer Wellness Center, Savina Chacheva. It's sure to be a fascinating conversation about the advances in surgical and medical options for pancreatic cancer patients. First, I want to extend gratitude to our amazing Wellness Wednesday partners, WEX, Wolverine Execution Services, and the Bellick family. It's because of the support of our great partners that we're able to do so much in the community like tonight's session. So thank you very much. Tonight's conversation is actually quite timely as we're in the midst of World Pancreatic Cancer Awareness Month. It's a time to put focus on this deadly disease, to raise awareness about the symptoms and the risk factors, to celebrate all of the warriors and caretakers, and applaud all of the researchers and medical teams, and of course, honor those who are no longer with us. Together, we can make a difference in the lives of so many people. We hope that you've been participating in all of our Awareness Month activities and look forward to seeing your continued photos and stories that you've been sharing on social media. There's been some great purple themed photos. So please keep doing that. And don't forget, this weekend, you can get some early holiday shopping in at the Kendra Scott Jewelry Store on Southport in Chicago, where 20% of the proceeds will be going to Raffle Foundation. And if you can't make it in store in Chicago, that's okay. We've got you covered. You could simply use the link and the code that we're putting in the chat here. And there's still time to enter our amazing raffle, where you could win an in-home dining experience with executive chef Hagop Hagapian. It's an award-winning chef, and not only will you be able to take the night off, you'll also be able to enjoy a multi-course gourmet meal for you and your friends. It's an experience of a lifetime, so be sure to get in on that. And again, you could see in the link will be in the chat. The winner will be announced live during World Pancreatic Cancer Awareness Day, which is actually next Thursday, November 18th, and we'll be announcing it at noon on our social channels. Your support helps fund Ralph's efforts for early detection research and patient support, two areas that are so critical in need of help. So thank you for that. Okay, back to tonight. For our friends joining us through Cancer Wellness Center, let me share a little bit about Ralph Pancreatic Cancer Foundation. We're a local Chicago organization with connections to some of the leading pancreatic cancer hospitals and organizations in the Midwest and beyond. Ralph provides personal and tailored support to patients, survivors, and families in crisis by connecting individuals with medical experts, personalized resources and education, creating awareness around risks and symptoms, and funding early detection research. Our hands-on approach ensures that no one has to face this alone. So what does that look like? We do this by directly connecting patients and families with medical experts and special resources. Ralph funds Ralph funds research because we understand that the best chance for saving lives is through early detection. And we provide ongoing education and support, like our panel tonight, to empower the families and the patients to make quick decisions with confidence. You could learn more about Ralph Foundation at ralphfoundation.org and connect with us through our social channels as well. We'll put the links in the chat section for more information and easy access to be able to find us quickly. Now, I'd like to welcome my partner tonight, Savina Chacheva from Cancer Wellness Center. Welcome, Savina.
Hi, good evening. Thank you so much, Erin, for having us tonight. And thank you everyone for joining us. For those of you that are new to the Cancer Wellness Center, I would just like to take a minute to let you know about the services that the center offers. The Cancer Wellness Center is a nonprofit organization that aims to improve the emotional and physical being of those diagnosed with cancer and their loved ones. We provide a variety of free programs and services, including education programs like the one this evening, wellness classes like Tai Chi, meditation, stress reduction, and support services that include counseling and support groups. Again, all free and there to support the families in need. Thank you so much to World Pancreatic Cancer Foundation for partnering with us today. And now I would like to give it back to Erin to introduce our speakers.
Thanks so much. And thanks again for your continued support and partnership. We truly appreciate everything that you've been able to do with us. So a few housekeeping items as we get started. You don't forget that you could ask questions throughout the entire session in the comment section below. And if you're not comfortable posting, then you can email them to us at info@ralphfoundation.org, and we'll be saving all questions until the end to make sure that we can get to as many as possible. Tonight, we have two incredible speakers. We're really honored to have these two doctors who are real amazing within their field. We have Dr. Mark Talamonti, professor of surgery at the University of Chicago Pritzker School of Medicine and chairman of the Department of Surgery at NorthShore University HealthSystem. And also Dr. Melissa Hogg, who is the director of HPB surgery at NorthShore University HealthSystem and the director of advanced robotic training for the Granger Center of Stimulation and Innovation. I'll let each of them share more about their impressive background and experiences. And first, I'd like to introduce Dr. Talamonti. Welcome, doctor.
Well, good evening, Erin, and thank you, Sabina, and thank both of your organizations for what you do for the patients with these incredibly challenging diseases. And you know, my first encounter with the Roll Foundation was actually about 25 years ago when I was a young assistant professor at Northwestern, and they were just getting their traction as a philanthropic organization that really wanted to make an impact in pancreatic research. And I was fortunate enough early in my career to meet the people from the Roll Foundation, and they helped me get my first external grant in pancreatic research, which led to the development of a pancreatic cancer database and a tumor bank at Northwestern, which we've now transferred over to the North Shore. So a great deal of gratitude and appreciation for the Roll Foundation and the role they played in my early part of my career. And in terms of the Cancer Wellness Center, I can't say enough about the selflessness that they show and demonstrate for patients with not only pancreatic cancer, but every form of cancer. It's really an extraordinarily selfless, committed group of people that do wonderful things for patients and their families. So thank both of you for everything you do, for the doctors that try to make a difference, and for the patients who so sorely need your help. And as Erin mentioned, I am a professor of clinical surgery at the University of Chicago, and I have the good fortune of leading the Department of Surgery at North Shore, where we've built a really great program in all facets of surgery, but none finer than what we've tried to do in hepatobiliary and pancreatic surgery. And we had a pivotal point in time 3 years ago when we were fortunate enough to recruit Dr. Melissa Hogg from the University of Pittsburgh. I'll tell you a little bit more about her background, but if you want to see see a program go to the next level with a singular recruitment, you have to see what Melissa's done for our program at North Shore, just by showing up and bringing all of her core values and her vision and her gifts to North Shore. She's really a special person. She was born in Northwest Indiana, grew up in Gary, Indiana, and like a good Hoosier, went to Notre Dame for her undergraduate years. And just to give you a personal perspective about how tough and gritty this individual is, she couldn't go to Notre Dame and just major in one field. She majored in two fields. She had two majors. One was in pre-professional, pre-medical studies, in which she graduated summa cum laude. And then her second major at Notre Dame was in media and film communications, when she stepped down a little bit and only graduated magna cum laude there. And following that, she attended medical school at Northwestern, where again, consistent with her gifts and skills and her perseverance, she was elected to the National Medical Honor Society, AOA, and was ranked so highly that Northwestern kept her as a surgical resident. And that's where I first got to know Melissa. I met her, I think, as she was a medical student, but really got to know her when she was a surgical resident. And again, was just so impressed by her grit and perseverance, which are two characteristics that make all the great pancreatic surgeons. And following residency at Northwestern, she then went to the University of Pittsburgh for a surgical oncology fellowship, and then stayed on staff there for 5 years as an attending physician. And what she's accomplished in her career at Pittsburgh, and now that she's transported to North Shore, is just nothing short of extraordinary. You know, Melissa is the entire package when it comes to an academic pancreatic surgeon. She is gifted with robotic technology, and so much so that she is, I believe, the only surgeon on the planet that has done more robotic Whipple procedures for pancreatic cancer than open procedures. So a pioneer in an innovative technology. She's taken one of the most formidable operations along with her mentors at the University of Pittsburgh and transferred a embryonic innovative technology and shown that you can take that technology and do that operation safely and effectively. But she'll go into more detail about that. She's also proven to be a real multidisciplinary surgical oncologist. And what does that mean? You know, it's one thing to be a surgeon that just knows how to do an operation. It's another thing to understand truly the biology of the cancer that you're operating on and the role that things like immunotherapy, biologic therapy, chemotherapy, radiation therapy play. And Melissa's CV is balanced between the technologic and the surgical things she does with robotic Whipples, but also the biology of the tumor and the impact that multidisciplinary care makes. And then finally, where I think she's really going to be famous for the next 20 years is what she's doing in surgical education. Remember, it's one thing to teach yourself how to do an operation. It's another thing to also understand the biology of the disease and the role of multidisciplinary care. But to really elevate your game, you have to be a teacher. You have to be able to impart that knowledge and that experience to the next generation of surgeons. And I think what she's done in the realm of educating people about how to use the robot safely, it's just beyond compare. I will tell you a short vignette about my own personal experience with robotic surgery. I was probably 60 some years old before I realized that minimally invasive surgery for pancreatic disease was not hypothetical, but it was real. I was at an international meeting in Sao Paulo, Brazil, when I heard Dr. Hogg give her presentation about the new paradigm for teaching robotic surgery. And it was different than anything we'd ever done in terms of teaching traditional open surgery. And I knew at that moment that there was a pivotal point in time in American surgery and certainly international surgery where you could take a curriculum that Dr. Hogg and her partners at University of Pittsburgh crafted, created, and modified, and you could teach those gifts, those special skills to another generation of surgeons. So I went out there and I spent three weeks with Dr. Hogg, and it was transformational. And when I came back to NorthShore and the opportunity came to recruit Dr. Hogg from the University of Pittsburgh back to Chicagoland and back to NorthShore, it was to me the one of the best recruits I've ever had the good fortune of completing. So without further ado, I'm going to introduce my extraordinary partner, a gifted surgeon, a wonderful educator, and somebody who has all the same core values that the Roll Foundation does in terms of advancing new techniques and new technology and new information to take better care of pancreatic cancer patients. So ladies and gentlemen, Dr. Melissa Hogg.
Hey, good evening, everyone. Thank you so much for that kind introduction, and thanks for the Rolf Center and the Cancer Wellness Center for allowing me the opportunity to talk more about, one of my favorite topics, and that's pancreatic cancer. And so, as I'm pulling up my slides here, we're going to be talking a little bit about advances in surgery and medical options for the treatment of pancreatic cancer. I do have disclosures that I teach courses on robotic training. So the agenda for today is to start out with multi-modality therapy for pancreas cancer. What's sort of the best evidence we have out there right now? How does that guide how we should treat patients for the best optimal outcome? And highlight how we've used those clinical trials here at NorthShore and some other opportunities that are ahead. Also, it's not only about treating pancreas cancer, it's identifying those high-risk patients and just talking about setting up clinics for those and treatment strategies for that. And end with something fun and talking about the minimally invasive approach to pancreatic surgery and how do we train the next generation. So I think, some of the most excitement with cancer therapy now is just keeping moving the needle by offering as many therapies as we can to hopefully have as best survivorship as we can for cancer patients. And, if we're going to look here, at pancreatic cancer, it's been a bad actor, for decades and decades. And this is a paper I like to show from Memorial Sloan Kettering, where it looks at the last 3 decades of pancreatic care. And we've come a long way with surgical therapy. You could see in 3 decades, 30-day mortality has gone down, 90-day mortality has gone down, 1-year mortality has gone down, because these are aggressive cancers. These are, major procedures, and the outcomes are getting better, as well as length of stay and post-op care is getting better. But unfortunately, in those 3 decades, we hadn't moved the needle much in terms of survivorship. So what is ahead? What can we do to help that? And some of this study has already been done, and we're kind of parlaying that for what the future is. So this is a randomized trial, Congo, which basically tells us that adjuvant therapy, so getting chemotherapy after surgery, is better for survivorship than if you don't. So this is sort of the first building block of what's the best way to treat pancreas cancer. But then if chemotherapy is good, is chemo and radiation therapy better? And the answer to that, based on this EPS-PAC1 trial, was no. Chemotherapy with radiation was not better. So that's also set the stage that it's not necessarily more therapy, but when to include it, when to not. That's really important. And so the next question was, how much chemotherapy? And really looking back at this SPAC3 trial, this showed us it's actually 6 months of therapy. So when I meet a patient with pancreatic cancer, before I get into anything else, I say, the next 9 months of your life is going to be dedicated to fighting this cancer. We want to get you surgery. We want to, let you recover. We want to give you chemotherapy, and we'll talk about the sequencing, but you essentially will need 6 months of chemo and surgery in its perioperative amount, because patients that get less than 6 months based on this study actually have less survival than if they got the complete 6 months. But what this study also showed, it doesn't matter exactly when you get that after surgery, but we try to give that chemotherapy afterwards within 12 weeks. So then the next thing, this SPAC4, was sort of the first study that showed combined, more than just GEM alone or 5FU alone, had better survivor than the single arm study. But also what this showed us was that if you had negative margins, and we've already known this in non-randomized data, but this one showed too with randomized data that negative margins is even better for survival. So really, we're building up a lot of information. You want a cure, you want surgery, but you also need chemotherapy. You probably need 6 months of chemotherapy. You need negative margins. So how do we use this information? Well, this study, barely had time to breathe on the PubMed before this next study came out. And this is sort of now what we're considering the standard of care for pancreas cancer in the sense of FOLFIRINOX. And so this has been the best survival to date, looking at median survival, which had historically been between like 20 months to 26 months, et cetera, after surgery. And this one showed a whopping 54 months of survival. So people getting 6 months of FOLFIRINOX, people getting surgery. And this sequencing is still for this study with surgery first, chemotherapy later. But many studies have showed us that, having surgery will sometimes derail people from being able to get chemotherapy, that maybe only half of the people will get chemotherapy after surgery. And really, the chemotherapy is just as important as the surgery itself. And that's why, as a cancer surgeon, it's important not to just say, I could cut the tumor out, but it's to say, I could be a quarterback and guide this patient to try and get them into the hands of everyone they need. Because it's very easy. Every person wants to come into your clinic and be told, oh, no sweat, easy surgery. You will take the cancer out and you'll be done. Don't worry about it. I wish I could tell people that, but I know it's not true. And I have to just really tell them, there's a lot we need to do, and we're here to get you through all that. So now there's been a paradigm shift, and I haven't gone through a lot of the data on why we've done this, but it has to do with negative margins. It has to do with people not getting chemotherapy. It has to do with better outcomes. And now we're trying to give chemotherapy upfront as much as possible. So having people being seen in a multidisciplinary clinic with their scans, getting labs, including CA19-9, giving them upfront therapy, and not only FOLFIRINOX, but gemabraxane, for between 2 and 6 months prior to surgery. Then we restage them, look to see, do they have a CT response? Do they have progression? Or do they have a CA19-9 response, and get them ready for surgery, which hopefully, and we'll talk a little bit more in detail about this later, can include robotic surgery. Then we talk about their margins. We talk about the response to tumor. We decide, how much more chemotherapy they need. Did they get all 6 months up front and don't need any more now, or did they get half up front and need half the back? And then also selective use of radiation, basically both in the pre-op setting and in the post-op setting potentially, but we don't hit as hard with the radiation as we do chemotherapy, because chemotherapy has been shown to improve survival. And that's what I tell patients. The number one patient-centered outcome is your survival. You know, we keep in mind all kinds of other things as well, but that's what patients are scared about, and that's what they want to know, that you have you do have their backs in that regard. And so, you know, what are some of the benefits of neoadjuvant therapy? It can decrease the T stage of the tumor size, decrease the end stage, so less lymph nodes, increase R0 resection, so negative margins, and better survival. But also, unfortunately, it weeds out early progression. There are some people with biologically aggressive tumors, you know, that may progress regardless of surgery, but they may have a better quality of life without the operation. And then also post-operatively, less complications, including pancreatic fistulas, which is somewhat the Achilles heel of many pancreatic resections. So some of the most compelling data, I really like this study from MD Anderson. And what this shows here is that if you have surgery first and have a major complication, you really have the same survival as if you had surgery first and no resection. And really what this isn't saying is you're not getting your chemotherapy after surgery because you had too many complications. However, if you have, you know, chemotherapy first and have major complications, you really have the same and better survival than patients that didn't have any complications. So really, you know, neoadjuvant not only improves patients' outcomes after surgery, but it's also improves their survival by getting them through and getting both modalities of therapy. And so, you know, as this paradigm has shifted nationally, NorthShore has shifted right along with this. So, you know, I had looked at some data, you know, older data, newer data, and, you know, we used to maybe be giving neoadjuvant therapy to a third of patients. So these might be people that had a lot of vessel involvement, you know, a borderline resectable, really bad disease. But now we were trying to give them to as many people as we can that come through the door. So 82% of our pancreatic cancer patients are getting neoadjuvant chemotherapy. And, you know, this statistics come out of PanCan a couple years ago that sort of for the first time ever, you know, you were seeing double-digit 5-year survival rates for pancreas cancer. And I remember when I was in medical school or residency, this was like 4%. So, you know, a lot of these changes are sort of having some downstream effects. And really that's because unfortunately the survival is low because half the patients present with metastatic disease. But, you know, this neoadjuvant approach and giving multi-modality therapy, I think is really improving the outcomes for this group of patients that have borderline resectable disease, which means some vessel involvements that you could still operate on, or unresectable disease, which means you have too much vessel involvement, you can't operate on them, but hopefully with the therapy you could downstage them. And that happens probably about 20% of the time. So you're giving those people a chance for long-term survival. So there's so many clinical trials that have recently closed or that are out now, but I want to highlight a few that we were participants of NorthShore and sort of how we're integrating this into practice. So, you know, still this question now, I told you about people looked into the radiation after surgery. Well, this Alliance study looked at, you know, the radiation before surgery. And so just to highlight, you know, one group got chemotherapy alone before surgery, the other person got chemo and radiation therapy. And sort of similar to the outcomes that we saw on that SPAC post-operative trial, the addition of therapy did not improve survival beyond what the chemotherapy alone did. So as much as we're learning about pancreas cancer, there's still so much we don't know, and there's still so much to debate. In fact, at many meetings, you know, academic meetings on pancreas cancer, it's still a hot topic. In fact, Dr. Talamonti had debated this very thing with one of the premier surgeons in Europe from Heidelberg. And so it's just still a hot button, but you know, we're just acquiring more data, and that's sort of the exciting thing. But it's not only about the multimodality therapy, it's also about the patient's outcomes, because if they have less complications, that actually means better oncologic survival. So this is another study that we recently have been a part of. And this study just closed. It hasn't been published yet, but it was looking at the best preoperative antibiotic to decrease infections after surgery. And actually Zosyn won. Hopefully I'm not giving away too much information, but this paper should be out later this year. And we are able to participate and put our patients on this trial. And the next thing, you know, I wish we knew more. I mean, there's some people that don't respond to certain chemotherapies, but respond to others. And we don't really have a way of knowing that yet. And so we're hopefully about to start a multi-institutional trial out there that actually looks at adaptive therapy for patients that are not responding to chemo and sort of drilling down on those. The ones that are doing great, keeping with the standard of care, but the ones that aren't, what can we find in terms of circulating tumor DNA biomarkers, et cetera, to determine how, which patients will respond to better therapy. So this is something we're hoping to get kicked off in the next few months, but there's a lot of people out there looking at this with the Know Your Tumor and other registries out there. But there's a lot of exciting stuff going on to keep the progression to fight this disease. And that sort of leads us into the high risk clinic as well. And there's a couple ways to identify high risk patients. Some are cysts, and then some are with genetic mutations. So this is a current study going on right now. It's an ECOG trial that we're part of, but it's really looking at low intensity versus high intensity surveillance. So, right now there's many different guidelines. As a surgeon, I follow the surgical Fukuyama guidelines, but there's also GI guidelines and other, European, Asian, et cetera, guidelines out there. So this is a study looking to see how often do we survey, because on the one hand, we don't want to miss anyone who's going to develop a cancer. But on the other hand, we don't want to operate on all these people that don't need an operation, because as I've told you, it can be morbid. So anyway, this is a very interesting study. It'll take a long time to accrue, but something that we're part of here at NorthShore. And this is something we're hoping to develop. Actually, one of the pathologists at Pittsburgh was really into molecular analysis. And so, molecular analysis of tumors, of et cetera, is just the hot topic, the buzzword across the board. And at our Society of Surgical Oncology, that's going to be in March, we have a whole program that's just devoted to sort of molecular targets for different cancers, pancreas being one of them, and pancreas cysts being another one of them, to decide, how can we detect things earlier? How can we target therapy more? How can we be more exact? And this is a study, looking at cyst fluid analysis, where the epithelial cells of cysts shed their DNA into the cyst fluid, and we look for molecular targets and have identified several targets. Now, a lot of this analysis is proprietary to Pittsburgh, but we've been in discussion with them about trying to send our patients cyst fluid there. And they probably have about a dozen institutions doing that now. So I think this is going to be, by and large, going to become the main way we determine how we operate on these cysts and how much we survey these cysts. It's going to be by looking at their molecular profile and determining, hey, you're someone at risk. Let's take you to surgery earlier rather than later, and saying to someone else, hey, you're not at risk. Let's stop imaging you every 6 months, 12 months, et cetera. And so that's really exciting stuff. When patients come with a new diagnosis of pancreas cancer, a lot of times they're like, my mom didn't have it, my dad didn't have it, I don't know why I get it. And I tell them, unfortunately, most of the time it's just bad luck, that most are sporadic, one cell went awry. And that's more common the older you get. But there are hereditary syndromes in genetic mutations, and they're all familial syndromes, which the familial are probably just genetic mutations we don't know yet. And there's some other risk factors like chronic pancreatitis and smoking. So I think, there's a lot more excitement being generated around this now. And I think a lot of this is just because the stigma of getting genetic testing is so much different now than it was a decade ago, as well as a lot of guidelines, including breast cancer guidelines, are essentially saying standard of care is having genetic testing done for tumors. So more and more people, and so sort of high risk clinics are really exploding. And with the 2018 NCCN guidelines, there is some guidance for the management of this. So I think this is a burgeoning area, but there's still a lot more that we can do. But I think just setting up these high-risk clinics for cysts and genetics, and this is something we've done here at NorthShore, and we're trying to teach our mid-level providers to do, and take on, to really take it to a next level, to be able to throughput a high amount of patients with screening. And virtual virtual clinic visits have been great for this. I think one of the great byproducts of the pandemic is, with your surveillance and stuff, you can really make things very patient-centered and easy for them to do. So now kind of moving on to the minimally invasive approach to pancreas surgery. And I think this is another one of the big excitement. I mean, we got to think about multi-modality therapy. We got to think about clinical trials. We have to think about molecular analysis, because these are just all the burgeoning areas. These are all the things that we currently have a lot more research on that have come out in the last, few years, but there's so much more to know, so much more to do. And while foundations like the Raffle Foundation, et cetera, are critical to help push some of this research, I think the next thing, is that we have to think about patient-centered outcomes. We have to think about technological advancement. And I think minimally invasive approaches to pancreas surgery is a great way to do that. And so, in 2019, there was an international evidence-based guideline on minimally invasive pancreas resection. And people came from, every continent, 50, 60 nations were included. Dr. Talamonti and myself were both part of these guidelines. And, looking at specific things like a distal pancreatectomy, this international Congress basically said, standard of care for distal pancreatectomy should be minimally invasive. And, and I think that open distal pancreatectomies is really a notch below the standard of care these days. We're well over 50, 60% are being done this way, but probably most should be done this way, in with the exception of some very advanced, vascular disease. Now, pancreatic duodenectomy, the Whipple, it's a bigger operation, and the data is not the same for it. It's saying it's equally safe, equally effective. There's nothing that makes it seem more dangerous or better than open either. So these are kind of considered equivalent. And just as I say, about 50 or 60% of distals are being done this way. It's probably about 15% for Whipples in the United States, but that number in the last decade has probably grown from about 3 or 4%. To about 15, in the last 5 or 6 years. So come in a decade, we may be talking about that being the standard of care as well. And so NorthShore, just keeping up with the Joneses, we've looked at our series and sort of the recent, we have about over 70% of our patients being done robotically, from where, half a decade ago, about 5% were being done robotically. And what have we seen in our own patient outcomes? And these mirror what you see in the published data. We haven't published this information yet, but decreased blood loss, increased lymph node harvest, and having read a ton of these papers, that's pretty much what you see out there, as well as decreased hospital stay and decreased wound infections. And really just with tiny little incisions, as opposed to a big incision, it really makes a lot of sense why those are the case. So what is robotic surgery? And I think, I get a lot of questions like, does the robot do my operation? What do you do, et cetera. And I was going to show you this little video to illustrate where, you move the robotic arms with your hands here, and you do the coagulation, with the cautery with your feet here. And you're sitting over here with this, high definition 3D, computer interface, whereas you're controlling these instruments here remotely that are doing the operating within the body. And this has been shown to have many advantages where you increase dexterity. I'm right-handed. And obviously kind of, a forehand, just like in tennis, is a lot easier than a backhand. Whereas essentially robotic makes you right-handed, left-handed, forehand just as easily as backhand, because it eliminates any tremor. It gives you more degrees of freedom. It has 3D visualization. It has amazing magnification and all these other little bells and whistles with visualization and dyes, et cetera. So it really basically is what I call a performance enhancing drug. It's like putting a computer interface between the surgeon and the patient to decrease errors and to increase just optimization of your OR environment. So now I'm going to have a little disclaimer for anyone who's squeamish out there. I'm going to show you guys some videos, first of the Whipple and then of the distal. And this is sort of how I break the Whipple down into 7 steps. But the uncinate retroperitoneal dissection is probably the most difficult and has all the blood vessels. So I'm going to show that for you here. And this is the robot. That's what you're kind of controlling off screen. And you see over here, this is the pancreas, this is the duodenum, this is that major blood vessel that's being attached to the liver. And what we have to do is essentially the pancreas wraps around this major blood vessel about 3/4 of the way, or what we call like 270-degree wrapping that happens during embryological development. And what we have to do is essentially unwrap the pancreas from this blood vessel. So you can see here that the blood vessel with a huge branch that's being attached to the pancreas is being dissected off. And just sort of slowly and diligently, layer by layer, we're going through every amount of tissue in order to make sure that we don't, get into a blood vessel that we don't want to give. And I know most of you that aren't surgeons won't know this, but the visualization that we can see here is about 10 times better. Because imagine, you add your arm's length, you add your torso length, and you add your head length, so about 4 feet away. And even though we can use some glasses that provide magnification, nothing provides this level of magnification. And so, I do this operation. You kind of have, like, for every surgery, 2 people, sort of a yin and a yang, in order to perform surgery. And so for robotic surgery, instead of someone being on the right side of the table, someone being on the left side of the table, someone is at the body doing laparoscopy, and you could see that suction to the right is someone standing at the bedside, and then you could see the robot is what I'm performing here. And I'm looking for an artery that hides behind this big vessel. So just essentially doing a Whipple becomes somewhat like a formula. First I find this blood vessel and I take it, then I find that blood vessel and I dissect it. And it's just like a stepwise, very, sort of tedious progression. But you want to do 2 things. You want to be as safe as possible, trying to decrease blood loss. You want to be as meticulous as you can, but then you also want to do as great of a dissection as you can to get all these lymph nodes in this area and be right on this blood vessel. That little blood vessel behind it's probably about 1 millimeter, so a lot of times you never even see that when you do open surgery. But really the visualization that the robot allows, and you could see me pointing everything out for several reasons, is one is, for the person operating with me, so we're, affiliated with the University of Chicago. So I have residents and fellows that assist me and, sort of, teaching them the anatomy, teaching them where exactly I want them to go. But also because I train a lot of other surgeons how to do this, I like to take the time to point out these blood vessels while I do the operation for teaching purposes. And so you can just see, here kind of a slow, meticulous, deliberate, approach to seeing every blood vessel that is possible in order to do this dissection. And you can see coming from below here, we're seeing that artery. That was the vein we took earlier. That was the artery dissected earlier. And now we're just kind of finishing everything off. Usually at this point, you're kind of, breathing a sigh of relief because you know that you found all of the important things, that you've gotten the margin that you need to get. And now, you're kind of in the home stretch. But this is a lot of fun. And I think that it translates to a lot of improved possibilities of outcomes in patients. And here's sort of the after picture, looking at, there's no more pancreas left at all. All you're left with this big blood vessel. That's the vena cava in the back, the biggest vein in the body. And that's why pancreas surgery is, is difficult, is that you have all these blood vessels here. So, as John Cameron, one of, the most famous surgeons in the United States, used to say, you're never more than a millimeter away from disaster. And then, he kind of liked that approach. I'm like, let me stay out of disaster at all costs. But next, the next most common operation done for pancreas cancer is a distal pancreatectomy. And this is where you kind of take the tail of the pancreas off. And for cancers, we take the spleen. And the sort of more difficult part of this operation is the middle step here of the vascular dissection and pancreas transection. So that's what I'm going to show you. And here, just kind of looking at the tumor, looking at the anatomy. You can see here, this actually patient has been radiated. This tissue you can see is a little boggy and a little bit swollen. And here, you see some of the blood vessels. This is the after shot when you take the pancreas off, seeing the adrenal, the kidneys, as well as the main, mesenteric vessels that we saw in the last one. So, and this is the spleen being lifted up, and that's the kidney itself. So again, for cancer surgery, everything is about getting a negative margin. So you have to do that with surgical technique, but the way you enhance that is preoperative therapy. And that's why I think neoadjuvant therapy is so critical, as you have a increased chance of getting a negative margin, meaning no tumor cell is left behind. And here we're taking the splenic vein, and this is that same vein you saw on the other side. And then this is the artery. Now we're looking at it on the other side because, before we were dissecting the patient's right, and now we're dissecting the patient's left. And this is all radiated tissue. And I know I was telling you, studies have shown not to do radiation. So we selectively do it when there's artery involvement, and we don't resect arteries, we resect veins. So anytime we're leaving an artery, we want to radiate that tissue to give it the best chance of killing all the tumor that we can. And again, and everything with cancer surgery is about your lymph node harvest. So the closer you could get to those blood vessels without going in, the more lymph nodes you're going to get. And taking every tissue away. So all you're leaving is the bare essentials for a negative margin. Those are the two most important principles for cancer surgery. And I mean, the visualization of how you can see everything with this robotic platform and do everything you can do open is really extraordinary. And so, when I was at Pittsburgh, I did the study on looking at oncologic outcomes after robotic versus open resection. And you can see we had sort of a non-significant, but a little bit of a spread where the red robotic, slightly better survival than open. But importantly, and, I always tell people, I'm a cancer surgeon, not a robotic surgeon. So it's always about the cancer. And the robot is a tool, but, no matter what profession you are, you want to have as many instruments in the toolbox as you can. So I think it just only enhances your ability as a surgeon to have more options out there. But it fundamentally comes down to biology. And what this shows us is that patients with adjuvant therapy do better. And that doesn't matter if you do the surgery open or robotic. They need to get their adjuvant therapy. Patients that have complications do worse. And it doesn't matter if you're open or you're robotic. You have to minimize your complications because that parlays to survival. And then neoadjuvant therapy, at least at Pittsburgh, how things were there, better survival. And again, we saw that more with the robotic surgery and sort of a trend here in the open surgery. But these fundamental principles are the same and they supersede any technology. However, on our multivariate analysis, we did show that the risk of death was decreased with robotic surgery. And I think that's multifactorial. And I'm not trying to say robotic surgery has decreased survival or has improved survival than open surgery, but it's not inferior. And the reason I say this is because, it's about more than technique. And, this is a slide I stole from my previous boss who studied at Halsted, but also trained at Pittsburgh, where these two giants of surgery, Halsted and Bernie Fisher, were there. And Halsted's known for this radical mastectomy, and Bernie Fisher's, noted for lumpectomy and all the clinical trials that went behind that. And so I think one point I want to give you is that approaches like technique, like robotic, right open, should not impact survival from cancer. But the principles of cancer surgery, the lymph node harvest, the meticulous detail of margin negativity, the neoadjuvant therapy, the minimization of complications, those things matter over and above all else. But you can see here that, more radical surgery could be more disfiguring in the case of breast cancer. And now that's not necessarily the message in terms of what I want to say in terms of cosmesis for what we do here, but there are other patient-centered outcomes and surgeon-centered outcomes that are important. And one thing I'll note, here's the visualization of how you see things robotically at the bottom and how you see things openly at the top. And here's an example of an incision, open, versus robotically. But I think what's more important is what are the patients experiencing after surgery. So this is a study, hopefully it'll be published pretty soon. We're under revisions in one of the journals, but it's a quality of life survey. And we look to see what's your quality of life after surgery. And non-surprisingly, when people are in the hospital after a major pancreas surgery, their quality of life goes down. I don't think it could really go other way. But how do you rebound? And what we showed was that upon discharge and after 3 months, improvement above baseline of quality of life was seen in robotic, but not necessarily open. And what about movements and patients getting around? So we put Fitbits on the patients after open and robotic surgery. And this manuscript we're starting to write up now. But what we saw was that people that underwent robotic surgery had on average per day. So this is each day after surgery. So you could see how as days after surgery go on, that goes up, but day for day, more steps after robotic surgery compared to open surgery. And so that's, fun and exciting. And that's also grounded in how the patient experience is. But I think, how do you go, from never having done a backflip to doing a backflip, and so that's where the training comes in. People could be great open pancreas surgeons, but when you learn a new technique, there's some more learning curve to it. So how do we minimize that learning curve while maximizing the emphasis on maintaining and improving patient outcomes? And so this is a training program I developed for Whipples, but I've used it in a lot of other avenues, because if you teach for a Whipple, you could teach for a surgery less complicated for a Whipple. So I'm not going to go into all the details, but I basically broke surgery down into about 5 different proficiencies, like mastering the instrument, mastering tissue handling, mastering the procedure, et cetera. So I built a training program, I studied it, I validated it, and instituted it in many different forums. And a couple of those, I'll talk about a couple of those in a second, but just the principle behind it is that look at this basic surgical tenet of needle driving. And you see here, this is virtual reality. So this is a backhanded, and this is a forehanded procedure here that we're doing. And then next, it'll go from the right hand to left hand. So this is kind of a left-handed, forehanded procedure. So this is a way to start learning this. You're on a computer interface. This is sort of a left-handed backhand that you're performing here. And you start things on your own time on a virtual reality simulator. And then you move on to this sort of inanimate environment where you kind of recognize the real world, not the virtual world, but still with basic drills. And then graduate once your proficiency is adequate in these deliberate practice models. And here you can see this is a anastomotic biotissue model I designed with a company called Lifelike. This is performing a pancreatic jejunostomy. And here you could see this being performed in a patient. So what I always tell people is like, who do you want to be doing your surgery? Someone who's gone through training, someone who's perfected the technique prior to coming into the operating room, or someone who's using you, or the patient as their first level of experience. So I really think that developing training programs is a game changer, and not only training surgery, but I think surgical education is akin to surgical quality. And really, the best outcomes come from, meticulous technical skills. And so what did we show for this? At Pittsburgh, we showed you could train, fellows how to do this. And so the participation in robotic surgery went up after this time period. The number of steps the residents were able to do on a Whipple had went up, and especially the most difficult, like I showed you, from that video, the resection phase, more could be done that way. And I don't have this data pictured here, but we transferred this knowledge with not only not a loss in patient outcomes, but an improvement in patient outcomes. And we showed this both for Whipple procedure and distal procedure, where using this training program as you go through generation 1, generation 2, generation 3, each step improves patient outcomes. So, this is not that you're letting someone else do it and you're compromising. You're training someone to be efficient outside of the operating room, and then you make them proficient inside the operating room, and patient outcomes get better. And that's, exciting stuff, at least for an educator nerd like myself. Can you do this outside of one little, program? And the answer is yes. So, Dr. Talamonti talked to you about a meeting he saw me at in Sao Paulo, Brazil, but he was not the only one inspired by this meeting. At this meeting in Brazil, Mark Besselink, who is a sort of a leading surgeon in the Netherlands, said, I want to bring this program to the Netherlands. So we did that. These are a couple of his PhD medical students that came, learned how to do the program, took it to each center within the Netherlands. And I used to fly there once or twice a year, that after they got through the training program and were ready to do their first surgeries, I was there coaching them, so I would go to Netherlands for a week and everyone's like, oh, that's so fun. I'm like, I was basically in the OR nonstop, watching people do robotic Whipples. So it is fun in its own right, but it's not as cool as, going to see the windmills and stuff like that. But what they showed, just the same training program, that I haven't really described in detail, but it's the same one I did in Pittsburgh. But basically we found that there was no negative impact of the first learning curve, and that this could be done in a whole country. And I think we ended up training about 20 centers throughout the Netherlands. And that was really exciting. But I think what's most exciting is the generational changes that will come from it. And I have several examples of this, but this one, is, I think, one of the bigger ones going on right now, is that once you train the next generation, then they could train the next generation. So this LearnBot program started in Europe a couple months after that LELAPS training program ended in the Netherlands. So now all those surgeons in the Netherlands are taking the training program that I developed, and they're using that training program to train all these surgeons in Europe. And even though that's great, because I don't have the time to maintain my practice here and then fly over Europe, how cool would it be to just be in Ireland one time, Geneva another time, et cetera. So they've I think about 8 countries that they've started in, and maybe about 12 or 14 surgeons so far. But this will be ongoing, for several years. But still, as we take this and disseminate these programs outside, we're still trying to advance them within our own institution. So I primarily dealt with fellows when I was at Pittsburgh, and now I primarily work with residents here at the University of Chicago, NorthShore. And here are a couple of my my residents taking part of the training program. And you can see this resident on the right is doing some virtual reality drills here. And this resident on the left is doing some suturing dry lab drills here. And this is kind of close up, but we have a beautiful sim lab, and have a couple robots and a few different simulators down here, which we can then teach all our general surgery residents how to do these things, and have programs for the urologists, gynecologists, et cetera. And sort of my next goal is to try and take this to the Chicagoland area. So in October, we had our first sort of Chicago-wide, and this is mostly the NorthShore University of Chicago, but we're here at UIC, and all the Chicago programs here are represented. And we have a meeting tomorrow about how to keep expanding these training programs within the Chicagoland. But not only that, just with this international reputation, we have a lot of international surgeons that reach out that have interest in learning how to do, pancreas research or robotic training. So these are a couple international research assistants I have right now from Argentina and from Korea that are here to learn more, not only about pancreatic research, robotic research, but also how to do some of these techniques themselves. So In conclusion, there's so much fun stuff going out there, and there's so much more to do. I mean, so we've learned a lot about the multi-modality therapy for pancreas cancer, and we know we need chemotherapy, and we know probably before, or a combination of before and after is good, but now it's like which one, how many cycles before, how many after, how to include radiation. So as many questions as we answer, there's so many more that we continue to generate. And it's just exciting, to be part of these trials, here at NorthShore. And I think, in terms of, also treating people that have the disease is trying to figure out new ways to detect the disease, and sort of, growing high risk clinics. And this is an area, where there's still so much to do, and so much excitement, because, a lot of scans, there's a lot of stress, it's a lot of money, et cetera. So, finding, markers, molecular signals, et cetera, that lets us know, who to screen more closely and who not to screen as closely is equally important. And lastly, I think that, 30, 40 years ago, no one would think lap choles, would be done, laparoscopically. And, some people that started doing that in the 90s were considered heretics, and it's crazy. And now no one would consider doing them open. And I think just, that was number one surgery being done by general surgeons, and very high volume surgery. And now, it's cycled through that, and then colon, and then stomach, and, pancreas, the beast, it's here now. And so this is kind of the era to make that shine. So I'd like to thank you for your attention, thank my partner, mentor, and all around nice guy and friend, Dr. Talamonti, who I always say, not only was my partner, but formerly a client, as he mentioned. And I always take this picture of the pre-test. This is sort of the first thing they ever do in the robotic training program. So I have hundreds and hundreds of these pictures holding up this little model behind a simulator. So anyway, thanks for your attention, and I look forward to any questions you guys have.
Wow. I just have to take a moment here. I'll invite Dr. Talamonti back as well. Dr. Hogg, that was incredible. If you could have seen me during the presentation, my jaw was out and dropped for most of it. So this was just so impressive. We'll open up for questions. We have a lot that have come through during the talk. And if, as folks are listening, please be sure to continue asking questions. And I want to remind everybody that this session is being recorded. And so we will be posting it on the Rolf website. So you will have access to it afterwards. Again, if you don't feel comfortable asking questions directly in the chats, you can do so by emailing us at info@rolffoundation.org. Okay, let's get started. So Dr. Hogg, you talked about 6 months of chemo after surgery. What about before surgery? Is there a set timeline that typically you'd like to have that run?
Yeah, no, that's a great question. And that's sort of what the current debate is now. So those studies that say 6 months, it's surgery first, then 6 months of surgery. We did a study just at Pittsburgh looking at any combination, and we did find that 6 months was a magic number. So say you got 0 before, 6 after, 6 before, 0 after, 3 before, 3 after. Anything less than 6 was worse outcomes, and anything more than 6 was no better outcomes. So there is some regression to that number, but I kind of, am more going towards a total neoadjuvant approach. So as much as you can give that before is better. But the reason being is because I think getting the patient all of their therapy is super important. So, if someone's sort of, dwindling off, not having the greatest time at chemo, and they're 3 months in, am I going to push it to 6 months and maybe, overdo it? No, you go to surgery, give them the time off and come back. But I think what you really want to see is you want to get all that chemo and surgery to the patient. So I used to be more like, if it's resectable, I would give them 2 months up front. If it was borderline resectable, I'd give them 4 months up front. And if it was locally advanced, I'd give them all 6 months up front and see if I could do the surgery. But now, I try and give as much of the 6 as I can, but paying attention to how the patient's handling the chemo so that you don't overdo it and derail them from becoming a surgical candidate. Because we did find that about 8% of people may get an infection, may get an admission, may get something, that could derail them from surgery. So you do want to prevent that from happening.
Thank you for sharing that. So we had a question come in about advocating for yourself. What if the doctor doesn't advise chemo after? Should you continue to push it? Is it important to cite the studies that you shared tonight to educate your care team? What would be your advice for folks?
Yeah, it's very interesting because I think for a doctor to not advise chemotherapy, that doctor is not following, the standard of care. And that's hard to hear, but I think advocating for yourself is important. It's a tough market in Chicago. And I would say that probably 2/3 of our patients get second opinions, or I'm their second opinion, et cetera. So I always encourage patients to get a second opinion. And I say, if nothing else, if you have 2 people tell you the exact same thing, then it should be reassuring. Or if they tell you the exact same thing and one is more convenient or you feel more comfortable with one person, that's equally important, because this might be the most important decision you make in your entire life. And you have to, go into it feeling good about it. The problem is that when you go to a couple people and you don't hear the same advice. And what I tell patients is that, because it's usually the opposite. The patients don't want chemo and I'm the one telling them they should. Mm-hmm. And I say to them, listen, I don't get paid $1 if you get chemotherapy, but I think it's the best thing for you. So that's, so believe me, that I'm sending you to do this because I think it's better for your overall cancer care, not because it's better for me. So yeah, I don't think there's any pancreas cancer out there where chemotherapy is not recommended. So if they're seeing a surgeon that's saying, don't get chemotherapy, then they should definitely see another doctor. And I'd be interested what Dr. Talamonti thinks about this.
I couldn't agree more. I think there are certain subtleties to what Dr. Hogg just mentioned, and second opinions are never a bad thing. Most of my practice now at this stage is second and third, being somebody's second or third opinion, but it can be confusing. And I would say a couple of caveats to what Dr. Hogg said. First of all, if it seems too good to be true, and you're getting rushed into the operating room with this particular disease, that's a good time to hit the pause button and get a second opinion, because the paradigm has shifted. It is no longer about how fast you can get them in the operating room, how fast you can do the surgery. There are better quality metrics than speed. The paradigm has shifted. It's about a multidisciplinary care, and just as important as what Dr. Hogg is implying here, is just as important as finding a good surgeon that understands the sequencing of the therapy. It's just as important to find a medical oncologist who is comfortable treating the patients with chemotherapy, whether they do it before, after, or some combination thereof. This is not the type of cancer, and it's not the type of chemotherapy where you need a medical oncologist who's doing all the other different specialties, does treat some kidney cancer, some breast cancer, some prostate cancer. And when a pancreas cancer patient shows up, he treats that patient. Just like you want a specialty surgeon, you should have a specialty oncologist who understands the nuances. Just like Dr. Hogg said, you want to give the therapy up front. That paradigm has shifted. Most major cancer centers and most major surgical oncologists who have a major focus on pancreas cancer acknowledge the benefits of neoadjuvant therapy, of upfront therapy. But you have to have a good medical oncologist who's not going to pound it in so hard, so relentlessly, that you weaken the patient to the point where they don't become a surgical candidate. They're too tired, they're too beat up to go to surgery. So I think that's an important nuance. And then I think the other point that Dr. Hogg brought up is the 6 cycles. Her research has shown that 6 is better than 3 or 4, but the other studies have shown that if you can't get 6, you will not get the full benefit of the therapy. So again, you have to have a good strategy is to give as much as you can before surgery, because after surgery, we know that even in the best hands, even when Dr. Hogg does an extraordinarily smooth, uncomplicated postoperative Whipple, some of those patients, up to 50% of those patients, won't get the postoperative therapy for a variety of reasons. And that's an irrefutable fact. That number never goes down. So get a second opinion, be open to the suggestion or the recommendation, more than a suggestion, the recommendation that somebody's going to want to give you chemotherapy for, as Melissa said, maybe up to 4 to 6 months before they operate on you, and be wary of the rush to the operating room. That may not be in your best interest. So I would echo everything Dr. Hogg said, and emphasize the need for being comfortable about getting a second opinion, and then understanding the logic of giving the therapy before surgery rather than just trying to pound it all in after surgery. 50% of the time, that never works.
And I appreciate the notion. I think oftentimes people think, well, if I get a second opinion, am I going to offend, my doctor, and the importance of actually going out and doing that. And so I take it that you work closely with the oncologist to make sure that the patient is getting what they need when they need. Is that correct?
Well, I'll take the first stab at that and let Melissa close on that, but unequivocally, just like you would not go to a medical oncologist who sporadically or doesn't regularly treat a woman with breast cancer, you'd never go to a breast oncologist who dabbled in it. Why in God's name would you take the most formidable cancer on the planet, pancreatic cancer, the hardest one to cure, and go to a medical oncologist that doesn't specialize in it? So at NorthShore, we have a handful of people that treat the patients with treat them medically in oncology with chemotherapy. We have 2 surgeons and I believe 3 or 4 oncologists. I think we just added our 4th one who does neoadjuvant therapy for pancreatic cancer. So in our shop, it's as important to find the right oncologist as it is the right surgeon.
Yeah, and we do that by making it easy. One is that, weekly multidisciplinary tumor board conferences where we put everyone in the same room, look at the scans with radiology, look at the path with pathology, have GI there, med-onc, rad-onc, et cetera. So part of that is weekly getting together to discuss, every case or the most challenging cases. And then also, physically, being in the similar areas. So, say the medical oncologist sees someone, that, hey, needs surgery, we add them into our clinics and vice versa. And I would say that I make just as many appointments to see me as I do to see the medical oncologist. Because if I see what their diagnosis is, I don't want that delay where they see me, I then refer them. I give them same day visits, so that they can kind of meet everyone and hear from 2 different specialties, how to attack and treat this disease. And so it's just basically by working as if they're your partners, like on paper, as they are just, sort of from a multidisciplinary environment.
Sure. Okay, our next question comes in from John. He says, I'm a stage 4 pancreatic cancer patient with the spread to my lungs. For informational purposes, I was diagnosed in October 2019, had FOLFIRINOX initially, a couple of others. 2 weeks ago, started gemcitabine. Sorry for my mispronunciation. Because of the severity, and then had to stop. And capecitabine, had to stop the capecitabine because of severity of mouth sores, close to trying again using week on, week off dosing. He says, I believe there's no surgery that Whipple is possible because there's the spread. Is that still the case, or are there any surgical options for someone who's had moved to stage 4?
Yeah, so that's a great question. And, everything, is a case by case basis. We did 2 studies at Pittsburgh looking at this specifically. One of the things is that pulmonary metastases tend to be more indolent than metastases to the liver or carcinomatosis. So we were specifically noting that patients that had pulmonary only metastases were living longer. And people on FOLFIRINOX have a, median survival of 11 months. So with you being over 2 years, you've already defied, that median odds and have done well with it. So depending on circumstances, there are cases where people will operate with stable or improved disease. And so indolent small volume lung disease may be one of them, or, a single or oligometastatic, meaning very few that can be removed at the same time. So, there's a lot of questions questions about what the tumor itself looks like in terms of, vessel involvement. But I would say the answer is not equivocally no, that it used to be in the past. But also for people out there, anyone with stage 4 disease, off the bat, should not be considering surgery because it's not in your best interest. But your story that you tell me 2 years out, I would say that there potentially is a role, but there's so much more information that would be needed. But with the pulmonary only, those tend to be more slow growing and favorable to resection down the road. And that was what we saw in one of our studies.
Yeah, I would echo everything Dr. Hogg said and add the caveat that when you have stage 4 pancreatic cancer, your length of survival, your quality of life is not going to be driven by whether or not you have the Whipple. Patients don't die from a tumor in the head of the pancreas. They die when it spreads. And controlling that spread of disease, and as Dr. Hogg said, a 2-year control is very, very unusual, very rare. Having said that, there might be a role to consider a combined type of approach where surgery might be factored in the very special patient who's got control of that distant disease. But remember, once you get stage 4 disease, your length of life and your quality of life is not going to be driven by having an operation that removes a tumor that's already gone to seed. And it's being driven by your ability to control that metastatic disease. And then in those very special situations, as Dr. Hogg said, that's when you want to maybe consider whether surgery has a role in that unique, highly selective patient population.
Okay. This next question goes back to the chemo or surgery first. I was told my brother needed to have surgery first because of a gastric outlet obstruction that was preventing him from eating. Are there circumstances that surgery might be needed before chemo?
Yeah, that's a great question. And that might be definitely a scenario depending on the quality of the tumor, meaning whether it's resectable with the blood vessels or not. But that, in a resectable tumor that you can't eat, that's definitely an option. There are ways, to potentially palliate that. One, to get you through chemotherapy. One is an endoscopic stent. However, the endoscopic stent, there are locations where this does not work well, and it does make you have to be on just a thick liquid diet and not able to eat normally. And then doing a surgical bypass in that scenario would not be ideal because thinking about surgery down the road, but it's not necessarily contraindicated. So in the right patient, I would definitely operate first if the patient couldn't eat because of that.
Anything to add, Dr. Talamonti?
No, I just think sometimes patients come and you can just look at them, and Dr. Hogg and I have talked about this many times. You just look at the patient and you're only going to get one modality. And sometimes you're not going to be able to give some old timer 6 months of therapy and then an operation, then maybe a few weeks afterwards of radiation therapy. And so sometimes there's patients where we say, the best chance of this patient getting therapy for their tumor is to take them to surgery first, because sometimes they choose not to have the chemotherapy. Melissa said our numbers were over 80%, but they're not 100%. And so it's really a selection process and using good judgment and trying to figure out the best way to deliver most of what they need to some of those patients. And it's not just elderly patients. Sometimes it can be a young patient who's really debilitated and has become malnourished. And you're not going to necessarily get that patient through 6 months or even 4 months of therapy, but that's always preferred. Sometimes you have to pay attention to giving them supplemental nutrition so you can get strong enough to get chemo and have even more time to do surgery. So there's no hard and fast rules carved in stone. It's about judgment.
Sounds like a big balancing act. You were talking about the different screenings and the MRIs. Who can people contact at NorthShore to be able to order the screenings? Is there a process that needs to be followed?
So it's not that universally screening is covered like to the general population. So typically, a lot of our referrals come from genetic testing when it's the case of, a hereditary pancreas cancer. So people that have any cancers, almost the NCCN guidelines will recommend this testing, or people with family histories recommend testing. So people that, that are concerned they may be at risk, we can refer to genetic counselors to get this testing. The other people that we screen are patients with cysts. So just as, ER visits or cross-sectional imaging becomes more and more popular, there's about 8 million pancreas cysts diagnosed each year. And of those 8 million, about 8,000 are actually pancreas cancer. So there's a lot of cancerous cysts out there. So I would say that anyone who incidentally, they had appendicitis, they had XYZ, but then someone also noted a cyst on the pancreas, that enough, they should ask their primary care referral to a pancreas specialist, and that person can order imaging. And that, what I would say, is probably about 90% of what I see is people that were in the ER for a kidney stone, and then were sent to me for a cyst, or people that had a breast cancer or some other cancer, and they got genetic testing and then were sent to me for pancreas surveillance. So I'm not sure if just, the general public will be able to get it and have it covered by insurance.
Okay. So as far as who qualifies for robotic surgery, is robotic surgery going to be standard in the future for every med student to learn? So this is kind of a multi-part question. Is there pushback from the old school, doctors? How do you see the future of that going?
Yeah, it's a great question. I would say that, just following history as an example, the answer is yes, to everything. So as an example is that fundamentals of laparoscopic surgery, a course is now being required for the American Board of Surgery for residents to graduate from residency, and that was probably, been the case for about 15 years. Whereas, 10 years before that, people were calling laparoscopic surgeon crazy, and then there's also now fundamentals of endoscopic surgery that's now required for surgeons to have that skill. So I think probably within the next decade, we will see a training that is requiring to have some sort of fundamentals of robotic surgery, although it may not be called that because there is already something out there with that name, but not for that purpose. But I think that it's going to be required for residents. And I don't have any of this data here, but if you look at the graphs of surgeries being done robotically in the last 6 or 7 years by general surgeons, it's just kind of straight up, the curve is exploding. And I would say that probably in 15 or 20 years, we're going to probably, quadruple the amount of surgeries that are being done now robotically. I'm interested to see what Dr. Talamonti with his gray hair has to say.
I think when I hear this question, I always quote Tom Watson, who used to be the CEO of IBM. And, their artificial intelligence is called Watson. Right. And when discussing technology, he said that technology is neither good nor bad. So it's not good technology or bad technology. It's how you use it. And remember, technology is relentless. So that robot that I trained on with Melissa 5 years ago is obsolete. And the next generation of robotic technology is going to make this machine right now, which everybody is enthralled with, it's going to make that one look like the Model T Ford. So the technology is relentless. And as I said in my introductory comments about Dr. Hogg, the key is teaching the next generation how to do it safely. And so Dr. Hogg and her partners and her peers will make extraordinary contributions over the next 10, 20 years. None will be more important. None will be more valuable to the patients they serve than how to train the next generation to do these operations safely. Because that's what's different than inventing computers or artificial technology. There's a patient's life at stake. And so the benefits of minimally invasive surgery, no, but we accept it for, as Dr. Hogg said, cholecystectomies, even colon cancers and esophageal cancers, prostate surgery. Remember when robotic prostatectomy started, People thought they were crazy. They couldn't do the good lymph nodes. The margins were all going to be positive. The operations were going to take forever. And then people had to do special fellowships in robotic surgery to be skilled to do robotic prostatectomies. Now, if you don't finish your general urology residency with a certain level, high number of robotic prostatectomies, that residency is in trouble and may not get accreditation. It's become the standard of care for early prostate cancer. So I think Dr. Hogg's timetable is probably right. Probably going to take about another 10, 15, maybe even 20 years to get there, but they're going to get there, and the technology is relentless. It's only going to get more pervasive, and the skill acquisition, the teaching of those skills is exactly where Dr. Hogg's going to make her biggest impact. I think it's inevitable. I saw the turn. I saw the pivot point, like I said, about 5, 6 years ago, and I said, you know, we have to do this. It's the future. We may not get there in my career, but I suspect that by the end of Dr. Hogg's career, this will not be a extraordinary thing to say we do robotic Whipples at our institution.
Wow. And as we've seen with the pandemic, everything has been remote. Do you think that at any point that because of the technology that it would be remote? Is it going to change the access of care at all?
Yeah, that's a great question. So that's why the robot was developed. It was actually DoD technology for soldiers in combat. That was sort of the initial push behind developing this remote technology. And they have actually done a cholecystectomy between New York and Paris, you know, where someone in one continent was operating on someone in another continent. So basically the answer is that's why it was developed. And yes, it's definitely possible. And, you know, there are different things like, you know, frequently people will come to NorthShore to watch us operate, to see us how to do the operation. And sort of one of my, you know, my disclosure is I'll go out only for people who have done training like mine. I will proctor their first cases, but I won't proctor or teach anyone who hasn't done any training because I don't think it's safe. But that's sort of what we do now. But they do have this something called InTouch technology with iPads that basically you could be in the room, they can hook you into the room camera, the robot camera, and you can guide these surgeries remotely. So that's available. It's at select centers now, about half a dozen. I've been trying to get it at our center, but I haven't been successful yet. But I think we're going to see that a lot more often.
Incredible. Anything to add, Dr. Talamonti?
Nope, I think she said it well.
Are you seeing more clean margins more often with the robotic?
Yeah, so it's a great question. It's kind of loaded for one reason, is that the AJCC staging system changed in 2018. So across the board, there have been an increase in positive margins in the last 3 years in any study. It's because it was before considered negative is negative. Now it's considered you have to be greater than 1 millimeter to be negative. So, you know, we've done studies comparing robot to open and are equivalent and better in some. The only caveat is in the last few years, you'll see across the board an increase in margin negatives, but that's not to do with the technology. It's due with the definition of staging. And the Royal College of Surgeons in Europe has been going by that staging system for, you know, over a decade. So it also depends on which the location of the studies, but equivalent margin negativity. And you can really see by that video how amazing the visualization is for those blood vessels. And you can't just see it that well open. So I think that in time, we'll probably even see that it's better. And we have seen that in some series, but for the most part, the bulk of the data says equivalent.
So our next question says, I have stage 3 pancreatic cancer. I'm 58-year-old female, and I have the mutant gene that puts me at risk for the cancer as well as breast. Would you recommend that I have my breast removed as a precaution?
So is it, one, I'm not a breast surgeon, and I'm not sure exactly what mutation is a BRCA2 mutation. There are differing guidelines for that. There are people out there that have those mutations and still have their breasts. I operated on someone for pancreas, and they've already had 2 breast surgeries, but have not had, prophylactic mastectomies. So they're, unfortunately, after 1 breast cancer, they're still at risk for another. And even after 2, they're at risk for more. So I would say that it's a tough decision. But if it is BRCA2, there are certain therapies that are more effective, basically platinum-based chemotherapy and PARP inhibitors. So if not done already, depending on your mutation, you should discuss with your medical oncologist mutational analysis, or even go to PanCan for Know Your Tumor Foundation, because you may be eligible for targeted immunotherapy. And those are some of the great innovations that we've discovered in the last decade.
Okay. So the next question goes back to screening. What screening can be done on a proactive, stay ahead of the beast basis? My father turned yellow on a Sunday, and by Tuesday he had 3 months to live. This was 14 years ago. So I live with the question of, is it growing inside me? And I just don't know yet. I want yearly scans and blood work, genetic testing, so that if it begins, I could catch it. Just like I go in for annual mammograms and every 3 years for colonoscopy, I'd like to baseline to have a baseline and then monitor my pancreas yearly. Is this available? Is it unrealistic? Is it, what would you recommend here?
Yeah, it's a good question. So I guess, to have familial pancreas cancer and be eligible for screening, it's usually 2 relatives. So I think that the first thing to do is potentially seek genetic counseling to determine whether or not you have a mutation. And then they can go through, because there are some syndromes, like Jimmy Carter had a P16 mutation. And even if there was only, 1 person in the family with pancreas cancer, there was half a dozen with melanoma. So I think it's very important to look at the whole family tree and see, because there's probably about a dozen mutations out there, BRCA2 being the most common and most recognizable, but some of them have other malignancies other than breast that they're linked with. So I think that's the first place to start before going on to screening, because risk stratification, it changes depending on what your likelihood is of obtaining it. And false positives can be detrimental as well. So you want to make sure you're looking at the right, that you're in the right group when you're being screened.
Absolutely agree. The first step is not to twist your primary care doctor's arm into saying you're going to get a special pancreas CT scan. That's not the first step. And no one has really shown that a CT scan of the pancreas is a good screening tool. That actually has been shown that it doesn't necessarily pick up early pancreatic cancer. So we're still in the era where a lot of research is being done on blood tests, urine tests, even to see if there's special proteins in the urine. We don't have a PSA like they do for prostate cancer. We don't have a mammographic radiographic test like we have for breast cancer. A cost-efficient and sensitive specific radiographic screening tool, we don't have that. We don't have a blood test that tells you your PSA, your pancreas specific antigen is going up yet. So we're in an era where that will be a major breakthrough, just like immunotherapy, just like neoadjuvant therapy, robotic therapy. We're still in need of a good screening tool. So I would strongly recommend that you start with what Dr. Hogg's recommendation was, is talk to your primary care doctor, see if you can get genetic counseling, and see if they take a good history. Sometimes you'll get that tripwire finding that allows you to have your insurance company pay for these tests. Now, whether it's a blood test, an imaging study, an endoscopic ultrasound, depending on what your family history is, there are strategies now that can be matched to the genetic risk that you carry, or the familial risk. But remember, the most common risk factor for getting pancreatic cancer is smoking and pancreatitis and age. So my own father died of pancreatic cancer. He was 81 years old. I diagnosed him with stage 4 pancreatic cancer and he died shortly thereafter. But my sister and I don't have a strong family history of any other hereditary cancers or any other familial syndromes that would even smack of a genetic test or a genetic syndrome. So, do I go get a CAT scan every year because my father died at 81 and he was a big time smoker back in the day? I don't, because I don't know that there's any data to suggest you need to do that or that it's even effective.
The next question is, it sounds a little bit as a hypothetical. So a 75-year-old female continues to get chemo treatments. She was diagnosed with pancreatic cancer over 5 years ago. She never got surgery and is tired, but has all her hair and drives herself to chemo. Are these outcomes average with cancer patients, or does it really depend person to person?
I wish.
I would say that woman won the lottery.
Yeah.
Okay.
Right.
Okay, so we're gonna wrap up. I want, and I'm gonna give you a heads up. I want from each of you your top 3 takeaways that you want people to walk away from this session with. And to our audience, if you have additional questions or we didn't get to yours, please send us an email at info@rolffoundation.org and we'll try and get those answered for you. And again, everything is being recorded and we'll send out afterwards. So Dr. Hogg, what would you say your top 3 would be?
So, just kind of following in my my presentation, one is if you have pancreas cancer, whoever you're seeing, whether it's a surgeon, radiologist, or radiation oncologist, medical oncologist, ask them about what all the therapies are out there and to be sent to talk to every one of them. Because, some people are candidates for immunotherapy, some aren't, some for radiation, some aren't, some for surgery, some aren't. Most are for chemotherapy. So one is if you have it, think multi-modality therapy. And how do you see every specialist to find out what's best for you? And if you need a second opinion, that's okay. 2 is for people that are high risk out there, find someone to survey you. So if you have the family history, if you have a gene, if you've, look at any CT reports because you went, for here or there, look to see if you have pancreas cysts. And if you do, get into a surveillance program. And lastly, if you are going to surgery, ask the surgeon if they do minimally invasive surgery. And if they don't, ask why not, or look for centers in the area that may have minimally invasive surgical options for them. So I would say those would be my 3 take homes.
Great. How about you, Dr. Talamonti?
Almost verbatim, almost verbatim. And I think there's a reason why, because there are certain paradigms now, certain things we know about pancreatic cancer that are irrefutable and undebatable. Patients who get multidisciplinary care or multi-modality care do better than patients who just get a quick operation. It's the totality of care that results in the highest survival rates. How you sequence that care, we think the data strongly supports at least a partial neoadjuvant strategy, if not a total neoadjuvant therapy. But the key to long-term survival with surgery is to understand that it's combined therapy that has the best outcome. And then secondly, I think, as Dr. Hogg pointed out, the standard of care for a localized pancreatic cancer in the left side of the pancreas is minimally invasive surgery. And minimally invasive surgery for a Whipple procedure is not heresy anymore. It's not radical recklessness. It's an acceptable, I think, an encouraged modality, but you have to find the right person to do it. You have to get somebody that's not on their learning curve anymore. And then thirdly, I think there's a strategy of surveillance for these pre-malignant cystic lesions, as Dr. Hogg said. I can't begin to tell you how many patients we see every single week who get a CAT scan for a kidney stone, an MRI because somebody wants to look at their aortic aneurysm a little bit more closely. And oh, by the way, there's these scattered small little cysts in the pancreas. And surveillance instead of surgery, observation instead of operation is perfectly acceptable for most of those patients. But you better, again, get yourself to a place that has that strategy and follows guidelines and an algorithm of care, so that if you do hit a tripwire finding on a subsequent follow-up, you're going to get a good surgery. But there shouldn't be a rush to surgery for everybody that gets a tiny little cyst discovered incidentally or accidentally on a scan done for some other reason. It's like an epidemic out there of these findings, and you have to be very judicious and careful that you don't over-operate on those patients, because most of them don't need surgery. But the ones that do, those are the ones you want to make sure get the operation they need.
Sure.
Those two would be my points.
Thank you. Thank you so much to both of you for not only sharing the information that you've shared today, but for the foresight in what you're doing and how you're teaching this to the next generation, and how you're really pushing forward in making sure that patients have the best care that's possible and available to them in the area and technology that we have these days. And I look forward to having another discussion and continuing to hear of all of your great work and see where this is going to go down the line. So thank you so much for sharing all of your important research and details with us again tonight.
Thanks for
Thank you
having
for
us.
the opportunity to participate.
Absolutely. And I also want to thank Savina and the Cancer Wellness Center for partnering with us tonight, and thank everybody who is here on the call for participating and leaning in on asking such candid questions. You know, as I said, we are recording, we're sending this out. If you're catching this on the replay on social media, please be sure to write replay in the comments and add your questions in there so that we could be sure to pass those along. And don't forget that to get your raffle tickets for our very special in-home dining opportunity, and continue to comment, like, and share Ralph's World Pancreatic Cancer Awareness Month posts. And join us next month on December 8th, where we'll be talking about breakthroughs in pancreatic cancer research and also the impact of your donations. You could find a link to register in the chat. And if you have ideas for future Wellness Wednesday episodes or speakers, topics, please email us at info@ralphfoundation.org. We'll see you back here next Thursday, November 18th at noon to announce the raffle winner. And also our board president, Rachel Scheinkopf, and our executive director, Stacia Hart, will be here to not only announce the winner, but talk about the research that you've supported and Ralph has supported this past year because of the donations that are coming in. As the doctor said earlier, you know, the idea that they're able to do their work because of foundations that are able to give them the research grants to do it. So we greatly appreciate that. And as we head into Thanksgiving and the holiday season, we want to know how grateful we are for each and every one of you out there. On behalf of the Ralph Pancreatic Cancer Foundation and Cancer Wellness Center, we appreciate you joining us tonight. Until next time, stay healthy and take good care. Good night.